How are you, sir?
So fine, ma. Good.
Yes, sir.
So we can start.
Yes, sir. Uh, we can start just by 5 minutes, sir. I'll introduce you, sir.
Sure.
Namaskaram, everyone. I would like to introduce Karthik, sir. Dr. G.S. Karthik, sir, is a DM nephrologist. President Dr. Sam G. Moses, gold medalist in internal medicine, as well as an ACLS instructor. Sir is much more beyond these 2 to 3 lines, very difficult to sum up. Thank you so much, sir, for always guiding students so well. And thank you for taking your precious time and sharing your knowledge with us all. Very delighted to have you here, sir.
Yeah. Thank you so much, ma, for your kind introduction.
Thank you, sir.
So yeah, if any more people to yet to join, or can we start off? I'll if everyone is ready, I'll share few slides. There are plenty, but I'll not share all those. Just let me see. Let me start saving. Just a second. Is it visible?
Yes, sir.
Yes, sir.
Yeah. Is this visible? Slide visible?
Yes,
Yes,
sir.
sir.
Yes, sir.
Yeah. Today's topic is role of pharmacy in CKD management, right? So we'll discuss more of case-based, evidence-based medicine rather than I'll not bore you by guidelines or any other thing. Sorry. So always is my habit which I got is to trouble students by asking cases. So we'll proceed with the same old procedure. Okay. So we'll start up with this case. Okay. So that it will be interesting and you will not be bored. Fine. So first of all, I want everyone to understand before proceeding to manage what is CKD is. CKD by definition is very simple chronic kidney disease. So I would like to know before proceeding to this case, how many of you understand what CKD is? I want random answers, please. No problem if you're wrong. I'm not able
CKD
to
is
hear
a
it.
yes.
Yeah.
CKD is a condition where the kidneys are going, where the kidneys are completely improper in their function.
Very good. Okay. This is one way. Any other?
There is a
Progressive
gradual
decline in
loss of
kidney functions.
Progressive loss in renal function. Okay. There is something someone was telling, some boy was telling. Yeah.
yeah, there is a gradual loss of renal functions.
Excellent. That is a more better way of defining CKD. So I understand that most of them. Yeah, somebody was telling something. Okay.
Structural and
So I
functional abnormalities for longer period.
wow, wonderful definition. This is what I was expecting. This is the actual definition of CKD. So who answered it? Very good, congratulations. So for longer period in the sense, what can somebody tell what is this longer period is?
More than
3 months, sir.
3
More than
months.
Very
three
good.
months or
Who
3 months.
answered 3 months? Excellent answer. The person who answered 3 months is excellent. So, so what do you understand with the structural or functional abnormality? How many? See the definition. Every word here carries some weightage. So we'll take examples of cases to understand this definition first. So you will know the concept in depth. What CKD is, when you will call a patient as CKD. Because, for example, if I tell a patient is diabetic and the patient has serum creatinine of 2.3 today. Again, after 6 months, I ask the same patient to come. Now the patient creatinine is 3.4. Again, after 6 months, I want to see the patient. The next time, the patient creatinine is 4.5. Do everyone agree that is CKD? Yes, or somebody has any doubt?
No, sir, I agree.
Yeah, because it is very simple. See, every time the creatinine is high, it is CKD, right? Okay. Now the same patient creatinine today is 3.3 at 2.3. After 1 year also creatinine is 2.3. Again after 5 years creatinine is still 2.3. How many of you agree this is CKD? Are? I'm telling a same patient having creatinine of 2.3 for 5 years. Is it CKD or not?
Yes, sir.
Yes, sir.
Yes. But few
Yes,
people
sir.
don't agree. If they don't agree, they can type what they have a doubt in the chat box. Okay. Fine. So as we'll see this case, how to make things more complicated, I'll tell you. 45 years gentleman, known case of diabetes. So everybody can see this slide, right?
Yes, sir.
Yes,
Yeah.
sir.
45 years
Yes,
gentleman,
yes, sir.
known case of type 2 diabetes since 10 years and hypertensive since 2 years. So routinely these days, it is a norm that we'll have routine health checkups. That is very common. People are getting it done. So on routine health checkups, CU shows only 1 plus proteins, and his 24 hours urine shows 270 milligrams of proteins, and he was also told that he was losing some 230 milligrams of albumin 5 months ago. Yes, his serum creatinine is 1.2, which was in a normal range which lab has given. The normal range of serum creatinine for a male patient is 0.8 to 1.2. Okay, so the options given to you guys are: the patient has CKD. The patient has no CKD but some protein losing kidney disease. And options is patient has nephrotic syndrome. Option is patient has AKI. Option E is none. He does not fit into any of the above. So how many of you agree with this? I want answers, please. I'm not able to see the chat box. I think I need to close the slide and look at the chat box. Okay, verbally you can tell. Any
B.
guesses? Wild guess. That's okay. If you make a mistake, I don't mind. This case is given to you guys to make very sure that you understand the definition correctly. I am not expecting a correct answer, but still, you can make guess.
Option B, sir.
Option B, sir.
B,
Yes,
sir.
sir.
Okay. Okay. So many of you probably are making a choice of option B, thinking that creatinine is normal. 5 months ago, it was 230 milligrams. Some protein was losing, and it has worsened to a little higher up. That's all you think. Okay, accepted. Let us take a second case. I will discuss this definitely. Now, this is a 65 years male presented with serum creatinine of 1.6. He is a known case of hypertension since 4 years and hypothyroid since 2 years and diabetes since 2 years. Now, how many of you think this is CKD? How many of you think it is acute kidney injury? And how many of you think if it is CKD, what stage it is? You agree this is CKD?
Yes,
Okay,
sir.
okay,
Yes, sir.
Yes,
fine.
sir.
Yes,
Yeah,
sir.
Yes, sir.
yeah,
Yes,
okay.
sir.
Many of you agree. Okay, we'll see now. So you have two cases in your mind. One case says that the creatinine was 1.2, but there was some protein loss from the kidneys. Okay, so thinking that there is some protein losing kidney disease, but it is not CKD. The second case says that there is a single value of serum creatinine, but nobody asked me whether it was the serum creatinine was rechecked again or what was the previous creatinine before this value. Okay, so there are two different scenarios. Now we'll see the definition first and how can we best fit. This is the definition given by KDCO. This is the standard definition of CKD. You can take a screenshot on your phones or tabs, and no definition beyond this is correct. This is given by KDO. So CKD is defined as an abnormality, as rightly suggested by someone, as abnormalities in kidney structure or function. which is present for more than 3 months with implications to health. Okay. So what do you mean by kidney structural abnormality? How do you detect? Because you can't see the kidney physically, nor you can examine and touch the kidney by physical examination, clinical examination. So the kidney structure abnormality means if you do an ultrasound scan, the normal kidney size is between 9 to 11 centimeter. If the size of the kidney is less than 9 centimeter on an ultrasound imaging, despite that the patient's serum creatinine is normal, we consider it as CKD. Okay, and that ultrasound has to be done 2 months, 2 times apart with 3 months of gap. Okay, so if you do the January today, January again, you should demonstrate the same size of the kidney in April again. So if the ultrasound size of the kidney is small in both the scans, then patient can ask you, my creatinine is normal, but still am I CKD? Then you should say yes, because the definition says there is a structural abnormality as demonstrated by ultrasound examination. That is first thing. Second thing, what else you can, yeah, somebody is asking something. Yes. Okay. Examination. For example, in January, you have seen a hydronephrotic kidney. That means a enlarged kidney because of the obstruction. The urine which is got obstructed is going back and the kidney size increases, gets swollen up. This is called hydronephrotic kidney. Okay. And this increased hydronephrotic kidney, if we demonstrate by ultrasound again in April after 3 months, so if the same hydronephrotic kidney is persisting, then it is a structural abnormality which is persisting. So again you call it as CKD. Though the creatinine may be normal, but it is very unlikely for these patients to have a normal creatinine, but these scenarios can arise. We call it as a CKD only. See, CKD does not mean always the patient should be on dialysis. CKD does not mean always it is stage 5. It is stage 1. Sorry. No. It is stage 1 CKD. Okay. So that is one example. Now, for the same patient, if I say today the patient has hydronephrotic kidney, if you do in the April, the kidney becomes completely normal on ultrasound examination. There is no hydronephrosis. Probably there was a stone which is causing hydronephrosis. The stone was removed by the surgeon. Now the swelling of the kidney, that is hydronephrosis, comes down and the size of the kidney is normal in the April scan. This you don't call it a CKD. Reason being, you have to define the being persistent for the next 3 months. So whatever abnormality you have, this should be same for the next 3 months. Hope you guys understood this, or any doubt until now?
Yes, sir, understood.
Very clear, sir.
Understood, sir.
Yeah.
Understood, sir.
Yeah, okay. Okay. So this is kidney structure. This single word has so much meaning. Now we talk about the kidney function. What do you mean by kidney function? How do you assess the kidney function? Again, the kidney functions are what? Can somebody list out the functions of the kidney? Simple question, basic thing.
Serum creatinine, urea,
Renal clearance.
Detox.
I'm not asking about the English.
clearance,
Wait, please.
Excretions.
Yeah,
Excretion.
I am asking about the
Excretion.
function. 1% at a time, please. I'm asking about function. I'm not asking
erythropoietin.
secretion. Correct. Erythropoietin secretion. Somebody said excretion, electrolyte balance. Anything else? Acid base balance. Correct.
Vitamin D regulation.
Vitamin D.
So urine
Stimulation of erythropoietin, sir.
Yeah. Erythropoietin, vitamin D, electrolyte balance, acid base balance, and excretory function. So all these are functions of the kidney. So how do you assess the function of the kidney? So how does a person understand that kidney is not functioning properly when all these functions are compromised? For example, if the excretory function is not good, then there is a rise of blood urea and serum creatinine, right? Okay. When the electrolyte balance is not proper, there is hyperkalemia occurring or there is hypokalemia occurring. There is hypernatremia or hyponatremia. Electrolyte imbalance occurs. So this is the way indirectly you assess in the lab the renal function. Vitamin D could be low. Anemia can occur because of the lack of erythropoietin. Okay, the hemoglobin goes low. What else? The filtration function of the kidney. How do you know? See, when you do a, why do you do urine examination? To know the filtration function of the kidney. Normally, in the normally in urine, there should be no RBC. There should be no protein at all. You agree that there should be no protein at all in the urine. Okay, if there is a leak of protein in the urine CUV examination, that means the glomerular filtration barrier is at fault, right?
Yes, sir.
Agree? Everybody understand the term
Yes, sir.
glomerular filtration barrier?
Yes, sir.
Yes, sir.
Yes, sir.
Very good. So whenever there is a problem in glomerular filtration barrier, the protein leakage occurs. So protein loss from 230 to 270 was not very significant. It is just 40 milligrams increase. But which is beyond 3 months. Yes or no? Because we recheck the protein loss again after 5 months, he was losing same or little increase in protein. Yes or no? So this proteinuria is abnormal as you agreed, and it is there for more than 3 months. So the function is of the kidney is lost. The filtration function of the kidney is lost or not? You agree?
Yes, sir.
Yes,
Yes, sir.
So according to the definition,
Yes, sir.
CKD is defined as abnormalities in kidney structure, and there is or. It is or not and. So either the structure or function. Here the structure is normal, but the function is abnormal, and we have demonstrated beyond 3 months. That is after 5 months. So now tell me, the patient has CKD or not?
Yes, sir.
Yes,
sir.
Yes, sir. Yes, sir.
Because many of you answered it is only some protein losing nephropathy. Now you got the definition and you know now that it is CKD. So your diagnosis changed completely. So convinced with my explanation?
Yes, sir.
Yes, sir.
Yes, sir.
Now,
Yes, sir.
I hope everyone is understanding what CKD definition is. So it is not very simple. So if you see more case scenarios, you will understand. It could be structure. CKD means everybody will think dialysis. Dialysis. It's not like that. CKD can start from stage 1 where the creatinine can be normal, but the patient can be excreting only proteins. Over a period of time, if you follow up that patient, the creatinine will definitely rise. Okay, so it's that is the because why it is so stringent definition. If you don't treat this patient of proteinuria at this point of time with normal serum creatinine, what I am telling is creatinine will definitely rise, and his creatinine progressively increases, and he will end up in CKD stage 5 for dialysis. So which is the better stage to enter in? Once the creatinine rises or before the creatinine rises?
Before
Before
the
Before
Yeah,
the
very
creatinine
good. You understood. Everybody are excellent. You got the concept. That is why this definition is made. So you want the treatment before some problem arises. You don't want to treat the patient after the problem is there, right? So with implications of health, because these things lead to problems in future. That's what the definition says. So he has given, see, what are the markers of kidney damage? As I said, albuminuria more than 30 milligrams per day. Okay, if the albumin excretion is more than 30 milligrams per day, that is abnormal. As I said, urine sediment abnormalities. When you see the complete urine examination, CUE report, if there are RBC in the urine, that is also abnormal thing. There should be no RBC ideally, or less than 5 RBC in the urine. But if you see RBC and red cell cast in the urine, that is abnormal. Electrolyte and other due to tubular disorder. As I said, persistent hyperkalemia or hypokalemia, and there is no other cause. For example, if the patient has persistent hypokalemia, there are various causes. If the patient is on diuretics, patient has a aldosterone secreting tumor that can cause hypokalemia, and various other causes. I don't want to list. If these causes are ruled out, and if you think the hypokalemia is due to tubular disorders of the kidney, like renal tubular acidosis, And if the problem of hypokalemia is beyond 3 months, that is also CKD. And abnormalities detected by histology. If you do a kidney biopsy and the kidney biopsy shows fibrosis, it is CKD. And I said structural abnormalities detected by imaging, ultrasound examination. Yes, so that is also CKD. And if the patient had a history of kidney transplant, that is obviously CKD. No patient will go for kidney transplant if he has a normal kidneys, right? So if the patient gives you a history of kidney transplant, that is obviously CKD. No patient with normal kidneys want to have a transplant kidney. Okay, or with the decrease in GFR, this everybody knows. If the GFR decreases to less than 60, it is CKD by any means. That is definite. So everyone knows this definition of GFR less than 60 ml per minute, but many of them do not know the above things. That's why I wanted to bring the two case scenarios and explain in detail what exactly CKD is. Now we'll go back to the second case and understand what I am trying to tell. Okay, this 65 years male with serum creatinine of 1.6 and known case of hypertension since 4 years, hypothyroid since 2 years, and diabetes since 2 years. So, what do you understand when immediately you see the serum creatinine of 1.6? First of all, you should think whether it is CKD or it could be AKI. Here, I do not know whether this patient is CKD or AKI. The reason being, I am seeing this 1.6 creatinine for the first time. So the first question of yours to this patient should be, have you checked your serum creatinine prior to this hospital admission? If the patient says yes, then you should ask, what is your normal serum creatinine? If the patient tells 3 months ago I have checked it and it was 0.8. So what your diagnosis would be?
AKI.
Perfect. It is acute kidney injury. Now rule out what are the causes of AKI now. If the patient says that my creatinine 3 months ago was 1.4, what do you think?
CKD.
Correct. This is the case of CKD, and he could have an acute kidney injury on CKD. This patient, tomorrow I repeat the serum creatinine, it becomes 3.2. So what do you think? Tomorrow only, immediate tomorrow, it becomes 3.2. So what do you think? CKD or AKI?
AKI.
AKI on CKD, not AKI. AKI on CKD. Reason being, he is already CKD, right? I told you 3 months ago his serum creatinine was 1.4. So CKD is confirmed. Yes. On CKD he can have AKI. So it is now this second case will fall into AKI on CKD. Okay. CKD patient can also have acute kidney injury because he has not progressed to stage 5. According to his creatinine, his GFR would fall around some 60, 40, whatever it is. So it is still not, it is not still less than 15. So still AKI episodes can go on. Fine. Understood, or there is any confusion in this? Patients with CKD, until they go to stage 5, stage 1, 2, 3, 4 can have AKIs. These AKIs we need to prevent because every AKI will progress the creatinine to a higher level. For example, a patient of CKD stage 2 comes with vomiting, loose motions, fever, acute diarrhea. Now his creatinine baseline was 1.6. Imagine 1.6 was his creatinine 3 months ago. Now he has loose stools, vomitings and fever. Now the creatinine rises to 5.2 because of diarrhea. This patient will label it as AKI or CKD. Okay, and treat the AKI part. That is IV fluids, antibiotics, whatever you want to give, you give. After treatment, the creatinine returns to 1.8, and he will be remaining on this 1.8 for the next few years. So, what did you understand from this case? The creatinine, because of AKI episode, which was maintaining at 1.6, rose to 1.8. So, what is the implication? Every case of CKD, you should be very careful that he should not have an attack of AKI, because any injury over to a CKD patient kidney will cause the creatinine to rise to the next higher level and he will maintain at that. That means the patient has progressed from stage 2 to stage 3. Yes or no? Agreed? Everybody are quiet. I think people did not understand. Hello?
Yes, sir.
Yes, sir.
Didn't understand.
Yes, sir.
Yes, sir. Agreed,
The
sir.
concept is clear or not?
Yes, sir.
Somebody,
Yes, sir.
somebody did
Yes,
not
sir.
understand can tell me.
It's clear, sir.
Okay. So CKD patients can have AKA episodes. So you should tell them as it is AKA on CKD. Don't tell it as CKD. Okay. So this is the definition. I think the concept is clear now. I just wanted to show this table, how the CKD is classified. See, as I told, even the albumin increase is classified as CKD. Okay, so there are 5 stages. Look into the left hand corner. The CKD classification is based on the GFR, glomerular filtration rate, and we give the units for it as ml per minute per 1.73 meter square. Okay, what is the normal GFR? Can somebody tell?
110 ml per minute. 120.
120 liters per
Correct.
day, sir.
Exactly. 120 to 125 ml per minute per 1.73 meter square. How did you get this 125 ml per minute? Interesting, no? How did you get this 125 ml per minute?
Population pharmacokinetic data.
Pharmacokinetic data, like how? Okay, let me tell you some interesting physics. Okay, it will not be boring, definitely. It will be very thought provoking. Okay, what is the normal cardiac output? It is 70 ml per beat. Yes or no? 70 ml per beat of the heart. So we had approximately. So normal cardiac output is 5 liters per minute.
Yes, sir.
7 into 7, 70 to 80 ml, and we have 60 minutes. We have 60 minutes, 60 seconds in a minute. Okay, approximately it is 4.2 liters, 4.9 liters, around 5. What is the normal blood in our body? 5 liters.
Yes, sir.
Yes,
Roughly, I'm
sir.
telling. I'm not talking about
Yes, sir.
definite values. So
Yes,
heart.
sir.
So entire this 5 liters will be circulated in 1 minute by the heart. Entire body. It is in circulation, right? So out of these 5 liters, how much percentage of this blood is going into kidney is 25%. Okay. So the renal blood flow 25% if you calculate, it is 1200 ml. Okay, 1200 ml per minute is supplied to the kidney. Understood?
Yes,
Yes,
sir.
sir.
Yes,
This 5
sir.
liters blood is distributed to entire body, out of which kidney receives 1200 ml. The remaining part is going to limbs, brain, everywhere. Per minute I'm talking. Okay. Among this 1200 ml blood, there are two components in the blood. Cellular component and plasma. Cellular component is RBC, WBC, platelets, whatever. Plasma, proteins, everything. And plasma. Okay? Yes or no?
Yes,
Yes,
sir.
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 Yes.
I strongly
Yes,
request
sir.
everyone to write this on a paper so that you will understand. From the heart, we are getting 5 liters of blood, among which, unless you do this calculation, you will not understand. Among which these 5 liters, we are receiving 1200 ml of blood is going to the kidneys. Among this 1200 ml of blood, we have two components, that is cellular component and the plasma component. The GFR of urine is nothing but water. Urine is made predominantly water. You are not getting RBC, WBC, plasma proteins, anything, right? In the urine. So it is coming from where? Plasma component or a cellular component? Urine is made up of what?
Plasma.
Plasma
Correct.
component.
Correct. Blood is half cellular, half plasma. So half of which would be plasma. Among 1200, half is plasma means how much?
600 ml.
600.
Correct. So 600. Now 600 ml of plasma is coming into the glomerulus. Okay. Among this 600 ml, it has to filter and produce urine. Okay. The kidney the kidney filtration fraction, the kidney what is filtering some amount of plasma, that is called filtration fraction. You understand? Fraction of the plasma is filtered by each glomerulus. Okay, that is called filtration fraction. The filtration fraction of is 20%. Normal. Now please calculate, if the kidney is receiving 600 ml of plasma, what would be the filtration fraction? It is 20%. So 20% of 600.
120 ml.
120. 120. That is your GFR. You understood how GFR we got?
Yes, sir.
Yes, sir.
Yes, sir.
This filtration fraction is 20%. So, see, it is physiology, how beautifully we can derive it. Your blood is 5 liters, among which 1200 ml is renal blood flow, among which half is plasma, because urine is nothing but plasma. That's why we are telling the kidney filtration excludes albumin, RBC, everything. Cellular components are not filtered. That's why the filter is so strong in the kidney. So the filtration fraction is 20%. Among the 600 ml, 20 divided by 100, that is 20% into 600 is 120 ml per minute. Okay, so this 120 minute, so both the kidneys together can produce a GFR of 120 ml per minute. Yes or no? Understood?
Yes, sir.
Yes, sir.
Yes,
So
sir.
both the kidneys will produce 120 ml per minute of GFR. So this is for 1 minute. So in a 24 hours, how much GFR is produced? Please calculate and tell me. This is per minute. So in an hour, how many minutes are there?
60.
Are?
Sir, 60.
Okay, 120 into 60, how much?
3200 ml, sir.
Okay, into 24 hours.
172.
How much it is? 172 liters. Yes or no?
Yes, sir.
It is 172 liters. See, at least we can tell this way. How many minutes are there in 24 hours? It is 1440 minutes. Yes or no?
Yes,
In
Yes, sir.
24 hours. In 24 hours, there is 1440 minutes. 1440 into 120 is roughly 172 or 180 liters.
172.8. Yes, sir.
Yes, correct. So per
Yes,
day
sir.
we are producing per day kidneys are producing 172 liters of GFR. That means per day kidneys are producing 172 liters of urine. Agreed?
Yes, sir.
Yes, sir.
Yes,
Are we excreting? Okay. Are we excreting 172 liters of urine?
No.
No, sir.
No, sir.
How much we are excreting?
1% of it.
Correct. What is 1% of it?
1.7.
1.2.
Roughly 2. Correct.
0.72.
Correct. That means roughly 2 liters. Yes or no?
Yes.
Roughly 2
Yes,
liters.
sir. Yes, sir.
What is the normal urine output? 2 liters. You only told no answer 2 liters. So you can derive everything. You need not remember things. So normal urine output for the person should be 2 liters, 2 to 2.5 liters, depending on the calculations. Okay. Yes, agreed.
Yes, sir.
Yes, sir.
Okay.
Yes, sir.
2 to 2.5 liters is the normal urine output. So 1% of this. So what is happening to remaining 172 liters of urine? It is being reabsorbed in the nephron.
Yes.
Okay. The nephron has two segments, right? Glomerulus and the tubules. The glomerulus is a filtration function. So the glomerulus is producing the GFR. That is 172 liters of GFR is produced by the glomerulus. Now We cannot afford to lose 172 liters of water per day. We have to drink, we have to have a water tank besides us if we are losing so much of urine, because we have to consume 172 liters every day. That's why God has made a beautiful tubules. These tubules absorb this remaining 172 liters of water back into the body every minute. That is whole day. If you calculate, the remaining all 99% is absorbed by the efficient tubules, long loop of Henle, other things. So we excrete only 2 to 2.5 liters of urine. You understood? Anybody who has not understood the concept, please ask me. This is very beautiful concept, which I try to make it easy, but somebody did not understand, please, you can ask that question. I'll just wait to understand.
So they are pair of kidneys, right? So
There,
they are a pair of kidneys
yes,
receiving 25% of blood. So
yeah,
each kidney receiving 12.5%.
yes, correct.
Okay.
I'm talking about both the kidneys combined.
Okay.
Okay. I hope this doubt was genuine and it is clear. So everybody understood probably. I presume that. Okay. So we are excreting normally 2 to 2.5 liters, and this is the calculation. Okay. Now just see the stages of CKD. If among this 120 ml GFR, if GFR drops below 120 ml, and if it is between 90 to 120 ml, we call it as normal or stage 1 CKD. Okay. You may ask me, see 110 ml is also CKD? I will say it's no, because if the albumin, for example, the patient has a GFR of 110 ml, but patient is having albumin excretion between this range of 330 to 300. If you see on the right hand corner, there is A1, A2, A3. For example, if the patient falls in this green zone, he is not at risk of progression. If he falls in this yellow zone, he is at light risk of progression. If he falls into its red zone, it is high risk of progression of CKD. Okay, the patient GFR, for example, is 110 ml, and he has a albumin excretion, for example, of 180 milligrams per day, 100 milligrams per gram. So where does the patient come in these boxes?
Yellow.
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 Yellow, yeah, yeah.
Yellow.
Correct, correct. So they come into this box, okay. So that is definitely CKD. Though the GFR is normal, he is excreting albumin. That means his filtration function is at fault. His glomerular filtration barrier is at fault. So he is definitely CKD despite his GFR is normal. I hope now the definition and these boxes are clear. Okay. If the GFR falls below 90 and above 60, it is G2. And G3 has been divided into G3A and G3B. Again, it is numbers from 60 to 45, 45 to 30, 30 to 15. If he reaches stage 5 below 15, he will likely to go for dialysis. Okay? No
Yes,
confusion in
sir.
this, right?
Yes,
Yeah.
sir. Yes, sir.
Yeah.
Yes, sir.
So I don't want to confuse with all these things. I'll just move on with few things, interesting factors. Uh, so now we'll see simple things. Simple things, because CKD patients are quite common, and most of the neighbors and at your own relatives can have a slight increase of creatinine. They can come and tell you my creatinine is 1.5. I'm perfectly normal, no problem. I showed to the doctor. He said that's okay. Then what would you say? You should, but doctor told me that it is some kidney problem. Would you like tell patient that you can do whatever you like? You can jump around, eat around, whatever you want. You go to any place and eat whatever you want because creatinine is 1.5, no problem.
No,
Would you
sir.
like to tell that? No. Would you like to suggest?
No,
No,
sir.
sir.
No, sir.
See, one more concept I wanted to introduce for all of you. For example, we have two patients, one at the age of 40 years and other at the age of 70 years. Both the patients have serum creatinine of 1.5. Whom do you think the CKD, do you think the stage of CKD would be same for both the patients because the creatinine is same?
No, sir.
No.
No,
No,
sir.
sir.
No,
No,
sir.
sir.
Creatinine will be different.
Yeah, correct. Reason being, naturally also, as the age progresses, the GFR tend to fall. So you should calculate. There are apps in the phone, EGFR app. You can take the help of the app to calculate the GFR. CG formula, which we are using, can be used for drug calculations, drug dosing. You can use creatinine clearance formula that is equal to GFR. That is CG formula, which you people commonly use, Cochrane and Galt's formula. Apart from that, for routine management of the patient in OPD, we use something called CKD EPI. CKD EPI formula that we have a ready-made app in the phone. You can download the app. You can just enter the data like patient is a male or a female, gender, age, creatinine value, race. You will get a calculated GFR. Okay, so for this patient who is 40 years, the GFR would be around probably stage 2, and for this patient of 70 years, 1.5 creatinine would be around stage 3B, higher stage. So both have a different stages. So you should be more cautious for a patient who has GFR at a higher, lower value, elderly, because they are at the more risk of progression of CKD. Okay. So how do you prevent? What do you suggest? Simple steps which we think we can see. What I want to ultimately suggest: patient management is not only drugs. Don't think we are here to give drugs only. And we need to check other things, and we can't take other things very lightly. We will prescribe only drugs and drugs will take care of everything. It's not like that. It is the combination of the lifestyle, diet, and the exercise and drugs ultimately which will help the patient to prevent. See how many factors are there to prevent the progression of CKD. So what is your role? Only drugs? How many of you feel my role as a pharmacology a PharmD student is only drugs? Do you think
No,
so?
sir.
No, sir.
No,
Yeah.
sir.
No, sir.
See, please, because you people are here. Yeah, you people are here to help the patient in the overall management to prevent the progression of the disease. See, so you can advise simple things like stop smoking. Alcohol does not cause progression of CKD. It does not mean that if you get a kidney patient, you can tell happily you can take whatever alcohol you want, but stop smoking. Yeah, never do that because alcohol has a side effect on liver. So, though the alcohol has no bad effects on the renal disease, but also advise stop drinking, taking alcohol. Because I have not put here the reason being alcohol does not have a major effect on the kidney, rather, it has a major effect on the liver. It does not mean that alcoholic patient, liver disease patient can happily smoke and kidney disease patient can happily booze. Does it does it happen like that?
No.
People
No,
understand that
sir.
way. Yeah,
No,
people
sir.
understand that way. No, no, no. If you tell stop smoking because smoking affects your kidney and stop drinking, it affects the liver, they'll think, okay, we can booze or we can smoke, vice versa in other diseases. So tell both together. I'm sorry, something happened. Yeah. So why to reduce salt intake? Okay, stop smoking. Why? Why stop smoking? How does it affect? Let us discuss small things in detail.
So it causes
Cardiovascular disease.
vasoconstriction.
Correct, it decreases the effect of nitric oxides, it causes vasoconstriction, it damages the endothelium, It causes progression of the atherosclerosis. So decreased blood flow to the kidneys, ischemia to the kidneys occurs, renal ischemia like myocardial ischemia occurring, renal ischemia occurs and causes the progression of CKD. Okay. Next is salt. How does the salt? Can you
Sir,
clearly see that?
yeah.
Yeah. Tell me.
Reabsorption of water.
Yeah, very good. Kidney patients already has a less urine output. If you give more salt, more water is reabsorbed. Urine output is already less, so more and more water accumulates. They'll have swelling of the legs. Just give me a second. Badri చెప్పు అయిపోయింది డయాలసిస్ ఎట్లుంది ఓకే బీపీ డ్రెస్సింగ్ మంచిగా చేసేయమ్మా మిషన్ డిస్ఇన్ఫెక్షన్ అండ్ సర్ఫేస్ డిస్ఇన్ఫెక్షన్ సర్ఫేస్ డిస్ఇన్ఫెక్షన్ కూడా చేసాయి పైన మళ్ళీ కోవిడ్ వార్డ్ నుంచి బయట షిఫ్ట్ చేసినాక డిస్ఇన్ఫెక్షన్ లోపల చేయకు మిషన్ బయటకు తీసుకొచ్చి సర్ఫేస్ డిస్ఇన్ఫెక్షన్ చేసి పైకి తీసుకెళ్ళాం ఓకేనా అట్లా అక్కడ లోపల నుంచి చేస్తే లాభం లేదు కోవిడ్ వార్డ్ నుంచి తీసుకొచ్చేసిన తర్వాత పైకి తీసుకెళ్లే దారిలో డిస్ఇన్ఫెక్షన్ చేయి ఓకే చెప్పు చెప్పు రేపు ఎవరున్నారు మరి డ్యూటీలో వాళ్ళకి చెప్పినావా బాలరాజు కూడా చెప్పు చెప్పి వాళ్ళ పర్మిషన్ తీసుకుని వెళ్ళు మళ్ళీ ఇవ్వని మంత్ లాస్ట్ ఇంకా ఆఫ్ మళ్ళీ లీవ్స్ అడిగితే ఇవ్వను నేను సరే Okay, I'm sorry for the interruption. So somebody was telling it is increasing the fluid. Hello, everyone are there, right?
Yes, sir.
Yes, sir.
Yes. So
Yes, sir.
reduce salt intake better because it increases the fluid retention. So reduce salt intake. You advise the patient go and tell your relatives or anyone whom you know. Reduce the salt intake. Just go and tell this word. Reduce salt intake. What will be the next question?
How much should I reduce?
How much salt?
Yeah, how much should I reduce? So what do you mean by reduce salt intake? It is a useless statement if you don't tell. So how much should you reduce?
It should be less than 2.5 mg daily, sir.
2.5 mg. You measure in milligrams.
Sorry, grams, sir. 2.5 grams.
Oh,
1 to 2
okay.
grams. Yeah.
Okay, today you go and tell your mother to put 2 grams of salt in sambar and cook for you.
Sir, in home it's not possible to do that.
Why?
Don't taking mission and we don't do that.
Correct.
In routine
So what
practice,
is the
it's
practical
difficult.
way of doing things? That is, see, I am provocating thought in you guys because we tell in the hospital, dietitian or anyone comes and tells, take only 5 grams of salt. And you reciprocate. How do you reciprocate it? That is what I'm telling. See, there is a concept. Please understand this concept. Salt is not equal to sodium. Okay. 5 grams of salt is equal to 2 grams of sodium because salt contains sodium and chloride. Yes or no? So when I'm telling, where somebody told it is 2.5 grams of salt, it is 2.5 grams of sodium, not salt. You have to advise take less than 5 grams of salt, okay, and that is equivalent to 2 grams of sodium. You people were aware of this concept prior? Salt and sodium?
Yes, sir.
No, sir.
Yes, sir.
Okay,
Yes, sir.
so somebody were aware that salt is not equal to sodium. So 5 grams of your salt which you take is equal to 2 grams of sodium. So you should tell that you cannot tell 2 grams of salt. It is too less. It is not palatable. You cannot eat. Okay, 5 grams of salt. So is equal to 2 grams of sodium. So how do you tell for a tell me practical purpose? We are here to practice, not to talk. So 5 grams, how do you tell? It is possible. Somebody, it is not impossible. 5 grams, how do you? So you ask the patient to get a weighing machine.
If you can spoon count can be used.
Just 1 second. I am getting a hospital call. Just रंजन बोलो जी बोलिए हाँ यूरिन का टैबलेट नहीं लिखे यूरिन का टैबलेट नहीं लिखे मतलब हसन पेशेंट बोल के कोई भी नहीं था अब जी जी गुड इवनिंग अच्छा यू वर इन द रूम नंबर 301 that doctor under Dr. Vinod, right? I have written in the case sheet. Okay. Sorry. That is tablet is Uriren D. URIREN-D. हाँ. Okay. Okay. Give it to. Yeah. Uriren R. Yeah, sorry. URAREN -D. हाइफन छोटा डैश देके डी लिखो यूरिन डी ठीक है नाइट टाइम पे लेना है नाइट टाइम ओडी नाइट टाइम ठीक है कितना दिन 3 मंथ्स के लिए ठीक है I'm sorry for the interruption. Just hold on for 2 minutes. आगे क्या हुआ मैं बोल रहा था ना ठीक है मैं आके देखता हूँ क्लास में हूँ हाँ मैं आ जाता हूँ वैसे बीपी कितना है हेलो एवरीवन हाय एवरीवन
Yes, sir.
Yes, sir.
Yes, sir.
It is not impossible. It is not impossible to say less than 5 grams. How? Tell me some more practical way, some more innovative ideas.
So we can say in teaspoon.
1 teaspoon.
Teaspoon, sir.
Excellent. 1 teaspoon is equal to 5 grams. 1 tablespoon is equal to 15 grams.
15 grams.
Yeah, 1 teaspoon is equal to 5 grams. 1 tablespoon is equal to 15 grams. So it's very easy. Okay, I agree that Indian teaspoons and tablespoons have various size and shapes and forms, everything. But still, at least this is the easy way of telling. Now you go and tell your mother that mother cook sambar with only 1 teaspoon of salt. She will understand better. If you tell go and cook sambar with 5 grams of salt, definitely nobody will understand. So no. Okay. Next, what is this? Eat a healthy heart, diet rich in fruits and vegetables, exercise regularly, maintain weight. This everybody knows. Control diabetes and monitor HbA1 levels. Control BP because diabetes and BP are the things which causes the progression of CKD, right? Okay. So what do you mean by
Yes.
diet? What diet you want to prescribe? Very important for CKD is diet. So what diet? Just give me random answers. Tuck, 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 tuck. Diet is
A
very
little
important
protein
than medical
deficient
management.
diet.
Protein, less
Deficient diet.
phosphorus,
Protein.
Protein you want to give, you want to restrict.
Less.
Strict.
Low protein
How
diet.
much you want to restrict?
Low
How
protein,
much you
high
want?
fiber diet.
Low protein,
Okay,
high fiber diet.
okay, fine. Tell me what phosphorus and anything else? Phosphorus or anything else? Potassium?
Low potassium diet.
Yeah, low
Potassium.
Low
So
potassium.
physical activity. So how much physical activity do you advise? At least walking?
30 minutes a day. 30 minutes.
150
45
minutes a
minutes.
week at least. 150 minutes. So you can see here what are the potassium rich foods. You can at least advise, you need not remember everything. See, remembering potassium rich foods is very difficult. Potassium poor foods you can remember better. So at least you can know common things which we eat. You should remember like banana, okay, coconut water, okay. See, winter squash, all this nonsense nobody will eat. Tomato, potato, you can tell sweet potato, spinach, people eat. Hmm? Uh, like yeah, pork and mutton you should avoid. Oranges, simple things. Okay. Low potassium foods. What can you advise? Apple, pineapple. Okay, watermelon, mm, papaya also is low potassium food. Even guava is a low potassium food. Jamkai, okay, that is also a low potassium fruit. So if you can advise simply, patient will ask. If you tell all these things, they will be confused. Just you can tell you can eat apple, papaya, pineapple, guava, watermelon. Okay, these things is sufficient to sell it as a low potassium food. Okay, now what are high phosphorus foods? These foods are favorite to everyone whom now I'm talking to. Pizza, burger, cheese, double cheese pizza, coke along with pizza, yes or no? Red meat. So all these which we are commonly eating these days are high phosphorus foods. It is okay for a normal person, but very toxic to the CKD patient as they contain lot of salt too. Yes or no? So you can tell that don't eat any of the junk foods. Okay, try to avoid junk foods and try to avoid red meat as it contains very high amount of phosphorus. So tell them avoid mutton. You can take fish and chicken once a week because it contains amount of protein which we required for the patient because it is very difficult to measure exact amount of protein which you are taking. You cannot measure the food with the weighing machine every day and take protein. Okay, so that can be done. Um, Fine. So we spoke about lifestyle, we spoke about salt, we spoke about food. Now we spoke about the risk factors like diabetes, hypertension, and these things to be controlled. Right? You understood until now, right? So there are some complications in CKD. Now I'm going to end this slide and we'll discuss the common things, scenarios. Show so that I can see your chat boxes. Okay, fine. Now there are complications in the CKD when the patient goes into CKD. Few complications occurs like first thing anemia, second thing is fluid overload, third thing is mineral bone disease, and uncontrolled hypertension. Fifth one is acid base imbalance. Yes or no? Because you people only told me that these are the 5 functions of the kidney. Like what? Vitamin D production. It is low now in CKD. So low vitamin D levels. So bone problems. Yes or no? Second thing, you told that erythropoietin won't be produced. So anemia occurs. Third thing, vitamin D determines the calcium and phosphorus balance. If
Yes.
calcium and phosphorus is low, then the bone related abnormality arises. You also told that kidney helps in acid base balance. So potassium rises, acid base balance, because it is excreting lot of acids. When the kidney is not functioning properly, the acid level rises. Yes or no? So that is also function of the kidney which is getting compromised. Fifth thing is electrolyte imbalance. When the potassium is in excess in the body, that indicates the kidney malfunction, obviously, because kidney's function is to excrete the potassium and sodium. So obviously increase in potassium. That's all. It is very easy to diagnose. Sorry, ma, you ask something.
Hyperuricemia.
Hyperuricemia also, yeah, increase in uric acid. So you need not mug up all these things. Just build your concepts based on the things which you know already. These are the functions of the kidney. When the patient goes into CKD, these are the functions which are compromised. So this is occurring. That's all is simple. So what do you want to do now? You only tell me the treatment of each thing. Patient of CKD has anemia, you agreed? So what do you want to do?
Iron. Yeah.
Erythropoietin injection.
Correct.
Erythropoietin.
Yeah, iron
Iron
supplements.
tablets.
Yeah, you are answering, Aditi. Yeah, iron supplements. After giving iron supplements, the still the
Ap-
blood don't improve. Still the
Appointed.
blood does. Should give erythropoietin. The reason being
Weekly once
erythropoietin.
erythropoietin, sir.
Yeah, erythropoietin, darbepoietin. Correct, correct. So the iron being still in the normal limits, because the erythropoietin supplementation is not there, definitely there will be a iron deficiency anemia despite good amount of, if you do a iron profile in CKD, yeah, darbepoietin, yeah, I agree. Uh, if you do a iron profile in CKD, you will find surprising results. The ferritin levels will be extremely high, up to 800. But still, the hemoglobin will be 6, 7, 8 like that. The reason being, chronic kidney disease is equal to chronic inflammatory state. Take this definition: chronic kidney disease is equivalent to chronic inflammatory state. In inflammation, though you have adequate iron stores, the stores will not be mobilized from the body. So the iron stores as it is. When you give erythropoietin, as the erythropoietin is deficient, the erythropoietin hormone goes to the iron stores, pull the iron from the stores and goes to the bone marrow and give it, and it gives to the bone marrow for manufacture of RBC. Very good. You answered one of the complication and treatment of CKD, anemia. Excellent. So next, bone related problems. What do you want to do?
Calcium supplements.
Calcium
Very good.
supplements.
Vitamin
Vitamin D
D
you have to
supplements.
give.
Vitamin D's.
Vitamin D is low.
D.
Take the vitamin D levels. If there is vitamin D level low, you give low vitamin D. Calcium will be low because vitamin D is low. You give calcium. Over. Now what is happening? Phosphorus is high. Huh? So what do you want to do for the phosphorus to get it low? I
Phosphate
told you.
binders.
Binders.
No,
Yes.
no, I'm not satisfied with your answers. First, you should tell diet. That's what I told you. Don't jump to drugs.
Avoid junk food.
Avoid junk food. Avoid high phosphorus food like red meat and junk food. Next is phosphorus binders. Okay. So I want some intelligent answer. Milk and aluminium. X. It is a phosphorus binder. How do you give? Okay, tell me what are the phosphorus binders available?
Sevelamer.
Yeah.
Lanthanum.
Okay. So I
Cal.
will give one case scenario. A patient with CKD has a mineral bone disease. Mineral bone disease is nothing but bone disease secondary to low calcium, high phosphorus, and low vitamin D and high PTH levels. Okay. So this patient has a calcium of 7.2, phosphorus of 5.8. So which phosphorus binder you want to give?
Sodium bicarbonate.
Amma, sodium bicarbonate is not a phosphorus binder.
Calcium gluconate.
Excellent answer. Calcium carbonate. So that's why as phosphate binders are two kinds. Calcium based phosphate binders, non-calcium based phosphate binders. Calcium based phosphate binders are calcium carbonate, calcium gluconate, calcium acetate, calcium citrate. All these calcium containing products are also phosphate binders. Non-calcium based phosphate binders is cevilamer hydrochloride, cevilamer carbonate, lanthanum hydrochloride, aluminum hydroxide. Okay, so for the patients who have hypocalcemia and high phosphorus, it is easy for you to give calcium based phosphate binders because calcium is also corrected, phosphorus is also corrected. For example, other patient has calcium of 9.2, phosphorus of 5.8. Now your cevilamer will become the answer. Yes or no?
Yes, sir.
Yeah, simple. So you have to do calcium, phosphorus for every patient to decide upon which phosphate binder you have to give. Okay. Hope this is clear.
Yes, sir.
So one is anemia we have done. One is mineral bone disease we have treated. So this is how you have to manage until the patient progresses to stage 5. Every stage the same management would be. Somebody said sodium bicarbonate. In which condition you will give sodium bicarbonate in CKD?
Acidosis.
Acidosis.
Acidosis, very good. Because sodium bicarbonate is an alkali, you want to give an alkali supplement when the patient is having acid levels because the kidney function is to clear the acid. When the acidosis is predominant, the acid is not being washed out. So you give sodium bicarbonate. You do the ABG or venous bicarbonate levels every 2 to 3 months and increase the dose of sodium bicarbonate based on your venous bicarbonate levels. Okay. So this is over. Then what else is the complication? Anemia you have treated.
Water retention.
Yeah. Hypertension. Hypertension, what is the drug of choice? Here yeah, correct. See, reason is
ARB. Yeah.
AC and ARB. Reason is many of the kidney patients have a glomerular filtration barrier defect, that is proteinuria. AC inhibitors are the drug of choice to inhibit the progression of proteinuria. Yes or no?
Yes.
Agreed?
Yes, sir.
If yes, how does it inhibit the proteinuria? Tell me. How does AC inhibitors prevent the leak of proteins into the urine? See, what is the mechanism of action of AC inhibitors? What does it do? First inhibits the angiotensin converting enzyme. Agreed. And ARBs inhibit the angiotensin 2 receptors. Correct. Somebody is answering decreases the intraglomerular pressure. That is the correct answer because when the AC inhibitor or an ARB acts in the efferent arteriole. Efferent or efferent? Confusion.
Different.
E or A?
Efferent.
E. E. Efferent arteriole. On A there is prostaglandins. On E there is angiotensin 2, efferent arteriole. So whenever the efferent arteriole is dilated, automatically the blood is shunted from the glomerulus to the efferent arteriole very quickly. Yes or no? So whenever there is shunting of the blood to the efferent arteriole very quickly, immediately, so there is a decrease in the intraglomerular pressure. As the intraglomerular pressure decreases, the filtration also decreases. As the filtration decreases, proteinuria decreases. As the proteinuria decreases, the progression of CKD is decreased. Simple. Yes or no?
Yes, sir.
So
Yes,
the
sir.
drug of choice becomes the ACE inhibitors and ARBs. You are only answering everything. So this is what the nephrologist does. Every CKD patient, this is what we do. What
Sir,
else you want
doubt,
to
sir.
know? Yeah.
సార్ ఇప్పుడు గ్లోమరల్ ఫిల్టరేషన్ రేట్ డిక్రీజ్ అవుతుంటే ఏసీఎస్ ఇవ్వచ్చా సార్ మనం?
Very good question, Nana. Glomerular filtration rate తగ్గుతుంటే ACE inhibitors and ARBs can be given provided that the glomerular filtration rate is decreasing not very rapidly. For example, as I told you, the person creatinine is 2.8 today, for example. Then next month you call him, the creatinine is going to 2.8 and next month is 3.8. Again next month it is 4.5. In this kind of scenario, if you are giving ACE inhibitors, you have to monitor the potassium very, very vigilantly and frequently. Because these are the patients. What is the side effect of ACE and ARB? Hyperkalemia.
Hyperkalemia, sir.
So you can
Hyperkalemia.
prescribe, but you should be very vigilant in giving these drugs. Okay, because there is a risk of hyperkalemia as the GFR is decreasing very rapidly. So your question is very valid. We can give in a patient whose creatinine is stable, whose GFR is stable. It is a we cannot give ACE inhibitors and ARB to every patient of CKD. You have to check the creatinine level subsequently in 2 to 3 visits. Once you feel that creatinine levels is stable, you have to give it. Okay, that answers
Yes,
your
sir. Thank you,
question.
sir. Yes, sir. Thank you.
Okay. So this is what the drug of choice to prevent the progression of CKD is ACE inhibitors and ARBs. Okay. So we have answered all the questions regarding the complications and the progression of CKD. One is diet, lifestyle, smoking, habits, anemia, CKD MBD, metabolic acidosis, hypertension control, diabetes control, and that's all. Vitamin D. Okay. So apart from this, anything you would like to do is important is vaccination. Every patient of CKD has to get vaccinated because their immune system becomes weak. So you have to vaccinate with three things like hepatitis B vaccine, pneumococcal vaccine, influenza vaccine. These are the three vaccines you have to give to CKD patients at any cost. Okay, they have to be vaccinated with these three vaccines to prevent the problems in future,
So
to
can
prevent infections.
so
Sorry,
can you say once more? Repeat,
hepatitis
please.
B vaccine. The reason being, once the patient goes to hemodialysis, because we are dealing with blood and blood products, which is being circulated in outside circuit, giving hepatitis B vaccine is very important because patient can have a contaminated needle or anything getting pricked and hepatitis B virus occurring for the patient and infection occurring. So if you give a vaccination, he will be protected. Okay. The next thing is the pneumococcal vaccine. These patients are more prone for pneumonia. So pneumococcal vaccine is much better, which will prevent the pneumonia. Next is influenza vaccine. Every year we have a influenza flaring up. It could be swine flu, whatever flu like corona. So influenza vaccine may help to some extent from patient getting more worse. Okay. Okay.
Okay, sir.
Yes, sir.
Okay.
Yes,
So
sir.
what if,
Okay.
so
Fine.
what if the patient is immunocompromised, sir?
What is the
Patient is immunocompromised, like
patient is immunocompromised? That's why we
can
are
you
giving
vaccinate?
vaccination. What I didn't get your question.
Like if the patient are unable to produce those T cells or are unable, so will you give hepatitis B or pneumonia vaccine for those
Very
patients?
good question. Very good question. Very good question. See, that's why this vaccination to be given in the early stages of CKD. That is CKD first, 2 and 3 stages. If you give these vaccines in the later stages of the CKD, like 4 and 5, the efficacy of the vaccine definitely goes down by 50% because the patient is immunocompromised. The antibody response mounting will be very less. For example, I will tell you a data study where they have tested by giving hepatitis B vaccine in various stages of CKD. If you give hepatitis B vaccine in first 2 3 stages of CKD, the efficacy was 75%. If you if you are given this vaccine in stage 4 and stage 5, the efficacy of the vaccine has dropped to 40%. Only 40% of the patients developed the antibodies. Remaining 60% could not develop the antibodies. So that is the reason. This question is very good. That is the reason after giving hepatitis B vaccine in CKD patient, we have to check the antibody levels of hepatitis. We have to check the antibody levels. If the antibody levels is less than 10 international units, we have to repeat entire course of vaccination again to improve the efficacy. Okay?
Thank you, sir.
Yeah. So this becomes the management of CKD incomplete. Stage 5 management is different. We can't discuss in detail. That is nothing but stage 5. is patient will be put on hemodialysis or dialysis, any form of renal replacement therapy. Can you tell me the best treatment for CKD stage 5?
Hemodialysis.
Huh?
Kidney transplantation.
Correct, not dialysis, Amma. Somebody answered kidney transplant. That is the best answer because natural things has to be replaced by natural things. So kidney transplant is the best answer for patients who are on CKD stage 5. If they have a donor, they can go for a transplant immediately. Okay, before going for dialysis, also CKD stage 5 patients, you should be aware of these things because somebody asks you if the patient is going into stage 5 CKD, if you diagnose it as stage 5 CKD, GFR is below 5, you can do a transplant before taking the patient for dialysis itself. It is the best option. There is no need for the patient to go for dialysis. You can directly go for a transplant. Okay, fine.
Okay, sir.
That is the best stage for secret. Now the few things you have to well remember. Once the GFR is getting lower and lower, you have to calculate the creatinine clearance based on the Cockcroft-Gault's formula or CKD equation, whatever way you want. Then your role comes into major play because most of the CKD patients are admitted due to acute kidney injury. As I told you, AK on CKD. You agree? So it is very important for you to calculate the GFR and adjust the drugs based on their creatinine clearance levels. For example, patient with CKD stage 3 of GFR of creatinine 2.6 is maintaining this 2.6 creatinine from past 5 years, right? So this suddenly he gets admitted due to acute myocardial infarction or due to some infection or whatever may be the reason. Definitely, it is very important you to calculate the drugs dosage based on this level of GFR and give it. You cannot give to the patient or for this patient as given in a normal patient, right?
Yes, sir.
You have to give this based on that is very important. For example, a patient CKD who has a creatinine of 2.6, let us take his GFR is less than 45. GFR is 45. Now he comes with acute diarrhea, his creatinine goes up to 3.6. Now, what is the diagnosis? Array, we are not able to answer. Why? Creatinine of 2. Huh?
AKI, AKI.
AKI on CKD.
AKM CKD. His GFR was 45. Yeah, AKM CKD due to dehydration. Now, please tell me what is his creatinine clearance? Last time I told you. Okay. Any patient with AKI, the creatinine clearance is directly less than 10. Okay. Though this patient of CKD has a GFR of 45, now you are calling him as AKI, right? So your drug dosage is based on the creatinine clearance, right? For this patient, once you label as AKI, creatinine clearance by default for every AKI patient is less than 10. Okay?
Yes, sir.
Yes.
Fine. Yeah, this completes our discussion for today. So any doubts you can ask.
Sir, this is
Hello,
Karthik.
sir.
Yeah, yeah, thank you, sir,
Hello.
for taking your time and explaining us all these concepts. So, and
Karthik.
actually, sir, sir, so this
Yeah,
session is part
definitely.
of a mentorship program, sir, which we are doing, and we have
Yeah.
taken 200 students, sir, from 200 different colleges.
Wow, wonderful. I
And
thank everyone for participating and hearing my lecture could be boring for longer time, but still I thank you for your patient hearing.
and we are actually
Definitely
live
not, sir.
streaming on YouTube, sir. So, so
Interesting.
yeah, students watching on YouTube also. Sir, actually, I have a question, sir. So I have seen few endocrinologists adjusting the doses of long-acting insulin before dialysis session. So can you just uh, add some points on?
Yeah. Okay. So what he's asking, I hope everyone understood. So first thing we'll break this into two things. Insulin is to be adjusted or not during dialysis. See, dialysis we are doing with a there is a filter. First of all, understand what is dialysis. There is a filter, and there are two compartments in the filter. One is the compartment called blood compartment. Other compartment is called dialysate compartment. From the blood compartment, the blood runs. From the dialysate compartment, the dialysate fluid runs. The dialysate fluid is nothing but a pure water called RO water plus some electrolytes. So whatever your solutes are there, excess amount of potassium, sodium, urea, creatinine, goes by diffusion from the blood compartment to the dialysate compartment by a mechanism called diffusion. Okay, because the dialysate compartment is lacking all these toxins or solutes, whatever is there. These are in excess in the body. Fine. At the same time, the dialysate compartment does not contain glucose. So simultaneously, there is a movement of glucose from the blood compartment to the dialysate compartment. So there is a risk of hypoglycemia always for a dialysate patient because of the lack of glucose in the dialysate compartment and the movement of glucose from the blood compartment to dialysate compartment. So irrespective of the type of action of the insulin, it is better to decrease the dose of insulin if the patient is experiencing hypoglycemic episodes during dialysis. Because what we have observed is most of the patients in on dialysis experience hypoglycemic episodes by default, because they are not allowed to eat during dialysis. Because the reason being, if you eat during dialysis, the blood is diverted to the abdomen and there is peripheral circulation flow which is reduced, which can lead to intradialytic hypotension, that is BP falling low during dialysis because of the blood pooling into the splanchnic circulation, that is in the abdominal circulation. So we tend to advise patients not to eat stomach full during the sessions of dialysis. At the same time, because of the 4 hours the dialysis session runs, patient might have had food in the morning. He comes to for example, patient may have had a breakfast at 8 o'clock. He comes to dialysis at 11 o'clock. The dialysis session runs for 4 hours. He does not eat. The glucose moves from the blood compartment to the dialysate compartment, and there is a risk of hypoglycemia. Okay, so these things which we are adjusting, the drugs and the insulin and the food the patient times, is not always fixed. The patient behaves as he wants. That is quite obvious. He can take the food at any time he want. It will not fixed. So it is better if you see a hypoglycemic episode during the dialysis, you better avoid any insulin, long acting or short acting insulin, before the dialysis or on the day of the dialysis with a reduced dose. That should be okay. Okay, Karthik?
Is what he used to do, like adjust the dose of long-acting insulin day before night and the
Yeah,
regular
correct. The reason
rapid-acting
being
insulin
this,
on the day.
because there is a many patients we have seen having very serious hypoglycemic episodes and becoming very sick during dialysis, having vomitings, intradialytic hypotension, and shock and all those things. So it is better to avoid these episodes during dialysis. So you understood the concept of diffusion. The glucose moves from the blood compartment to the dialysate compartment, and they can cause serious hypoglycemic episodes.
Sir, how much time do you have, sir, for question and answer session? So
You
actually schedule
proceed.
is 30. Okay. So next, did you drug-induced cases of CKD, sir, where patient went into stage 5 and because of abuse of drugs?
Drug-induced CKD. Most of the CKDs we have seen is herbal nephropathy CKD. Many patients, whatever Indian belief is, if the patient has CKD, most of them go for herbal drugs, Unani medicines, herbal drugs, and they land up in CKD because all the herbal medicines contain heavy metals, including cadmium, mercury, arsenic. All these heavy metals are not completely filtered by the kidney. These heavy metals get deposited in the kidney and they cause tubulopathies. These tubulopathies definitely cause interstitial fibrosis, cause acid base imbalance, cause electrolyte imbalance, and they lead to ultimately to progression of CKD. So most common cause of drug-induced CKD which we have seen is herbal nephropathy. It is very unlikely for ACE inhibitors and ARBs and other drugs to cause CKD. Next common things which we commonly see in older age, NSAID induced nephropathy causing CKD. So innocent nephropathy, because our Indian scenario, most of the patients have knee pain, joint pains. If you ask any of our parents or older grandparents at our home, they say that we have knee pains, and they keep on popping up pills without our knowledge, and they visit the multiple doctors for the knee pains. So they tend to take more and more NSAID consumption, which causes papillary necrosis. These NSAIDs go and act at the tubular level, which is at, NSAIDs induce AKT. These papillary necrosis occurs, and once there is a papillary necrosis, they tend to slowly progress to CKD. So these are the two common scenarios, like herbal nephropathy, which causes and progression to CKD. NSAID-induced nephropathy is very, very, very common, as many of the elder patients, because of they cannot tolerate knee pains. Most commonly is knee pains. They keep on popping up pills. Third thing is farmers. Farmers, there's something called CKD-U, CKD of undetermined origin. These days we are calling as Uddanam nephropathy or Srikakulam nephropathy, because in India there are only few. This CKD-U we are seeing, like we are seeing most commonly in Andhra Pradesh, that in Srikakulam and Orissa and some parts of Bihar. Other places it's not seen. There mostly we see in sugarcane farmers, where they cultivate sugarcane because they work in hot sun. They don't take adequate water because they're tired throughout the day. They take NSAIDs because of the body pains, and because they work in sugarcane farms, they tend to take lot of fructose. They take sugar canes to quench their cane juice, which contains lot of fructose, and that increases the uric acid levels in the body. The uric acid crystals go and deposit in the kidney and cause nephropathy. So these are the farmers who take lot of fructose diet, and other people who take lot of cool drinks. It contains lot of fructose and uric acid, and they take less amount of water, and they keep on popping up pills for NSAIDs and NSAIDs. They'll end up in this nephropathy. These are the three conditions, Karthik, which we have seen very clearly, and we have investigated the drug-induced nephropathy. Okay.
So thank you. So maybe we can do for 10 more minutes, and if anybody
Yes,
has a question, we can
definitely.
ask.
So I can see some questions in the chat box. Thank you, sir. Satya has asked, hi sir, a 45-year-old patient, known case of hypertension, diabetes, CKD, hypothyroid since 4 years, freshly diagnosed with antiviral MI. How to manage her medication? Her serum creatinine level is around, question from YouTube. Creatinine level is 4.3. That is what I was telling. See, CKD means what is her baseline creatinine? Is this 4.3 fresh, or the 4.3 was her baseline creatinine? If her baseline creatinine would be less than 4.3, this is AK on CKD. Okay, so this AK on CKD, the creatinine clearance becomes less than 10. You have to adjust the drugs which is there. For example, in antiviral MI, the most you need not adjust. You need not adjust dyslipidemic agents. You have to adjust heparin. The heparin adjustment should be based on the creatinine clearance of less than 10. Had it been this same patient had the creatinine of 4.3 in the last few months. So this is only CKD. Now, based on this age, you calculate the creatinine clearance. It could be around, let me calculate with the app. Okay, and just tell you. This patient has no acute kidney. This was a baseline creatinine. I am calculating with an EGFR app in my phone. Creatinine is 4.3. Age is 54. Is a male patient. 54-year male or female? I do not know. Let me consider it as a male. And race is Indian. So his GFR is 15. Had it been the creatinine is 4.3 since long, his GFR is 15. So you have to adjust the drugs based on the GFR of 15. That is stage 5. Okay, that answers the question probably. If in doubt, you can repose the question. NSAID induce AK learning to CTK, CKD, yeah. Question from YouTube. Uh, the same question. 54-year-old patient CKD. So
Yeah, yes, sir. So any other questions you can ask. So chat box
yeah,
లోనే answer చేసేసారు sir. So in
I would like to know about the usage of aminoglycosides in stage 5. It is better to avoid aminoglycosides in stage 5 CKD. Okay. So if you are situation like you want to use for some infective endocarditis like thing, if the patient is on hemodialysis, there is patient is anuric. For example, if the I'll tell you a scenario. There are two patients. For example, one patient is on stage 5 CKD on dialysis. Other patient on stage 5 CKD also dialysis. Because one patient does not have urine output at all. Other patient on dialysis has at least 1 liter urine output per day. That means this patient who has 1 liter urine output per day, we call it as residual renal function. That means there is definitely urine coming out through kidneys. That means some function is there. That is called residue function, some amount left. So residual renal function. In such a kind of patient, if you give aminoglycosides, there is a chance that urine output may further fall. Your aim is to prevent this fall in urine output, because whatever extra fluid is coming out through urine, that is the advantage for the patient. You are doing removing 3 liters through dialysis extra, 1 liter is coming out through urine, that is good, because that 1 liter contains at least some amount of solids which is flushed out from the body. In those kind of patient, it is better to avoid aminoglycosides unless it is very dire situation like you have to give. Patient who are anuric, there is no residual renal function, he's on dialysis anyway. In those situations, you can always give aminoglycosides. Praveen Kumar, hope that answers your question.
Good evening, sir.
Yeah.
This is Pratik speaking. Sir, you told that main causes
Hi,
were.
Pratik.
Hi, sir. So you told that the main one of the main cause was herbomineral drugs, sir. So
Yeah.
if it were to detect early, or what, so the prognosis would be same as any other CKD, or is it worse if it is caused by herbomineral drugs?
The prognosis would be same, because if you are detecting early, you would definitely stop it. You could
Okay.
definitely stop intake and progression.
Okay.
You can prevent the progression, Pratik, but you cannot reverse it back, because any injury in CKD heals by fibrosis. The fibrosis is permanent. You cannot take the CKD patient, if it is herbal induced nephropathy also, to back to normal GFR. You can prevent the progression, that's all. But compared to diabetes induced nephropathy, hypertensive induced nephropathy, the prognosis is definitely better, because once you stop, the creatinine is held there, that's all. But in diabetes, it is a metabolic disorder. Hypertension is a metabolic disorder. Despite you control well, definitely some dysglycemia and hypertension is going on in the body. Unlike in herbal nephropathy, once you stop the drug, there is no further insult. So progression of CKD would be definitely much slower compared to these disorders.
Okay, sir. Thank you very much,
That
sir.
answers your question, Pranath? Yeah.
Yes.
Thank you,
Good evening,
Pratik, for
sir.
participation. Yeah. Good evening. Good
Sir,
evening.
this is
Tell me.
Harita.
Yeah.
Sir, actually, in practical scenarios, uh, do are pre-probiotics, that is symbiotics, prescribed for a CKD patient right from their stage 2?
Yeah, there is a study actually with probiotics and prebiotics, but there is still a controversy going on that whether it is beneficial or not. There are few studies telling that it may be beneficial. I'll tell you the exact reason for that. In CKD, because of the uremic environment, there is a gut dysbiosis occurring. Gut dysbiosis means there is more of a harmful, let me put into simple terms, harmful bacteria growing compared to the healthy ecological niche in the gut.
Yes, sir.
So once
Yes, sir.
there is a harmful bacteria growing, it secretes indoxyl sulfate, phenyl sulfate, and many
Precresol
other,
sulfate. Yes.
yeah, precresal sulfate, indoxyl sulfate. TMAO, and all these things are secreted. So
Yes, sir.
these are called small solute uremic toxins and middle molecule uremic toxins. These middle molecule and small solute toxins are toxic to our endothelium. It
Yes.
will cause acceleration of the atherosclerosis and further worsening of this cardiovascular disease. So there is a chance that prescribing prebiotics and probiotics
Yes.
or symbiotics in these CKD patients may prevent the progression of CKD, but it's not confirmed in every study. Okay, that answers your
Yes.
question, ma?
Yes. Yes. Thank you, sir.
Before or after dialysis, sir? No, this is not an infective process, so you need not need antibiotic before or after dialysis. There is no infection occurring here because the water which is getting exchanged between the blood is the ultra pure water, RO water. The water runs through the RO system and get exchanged. Okay. Is there any genetic mutations also associated with CKD? Very good question, Anuj. Many of the CKD disorders which occurs in children is due to genetic mutations. See, in CKD we have two types of CKDs. One is due to chronic glomerulonephritis, other is due to chronic interstitial nephritis. Many of the these are the two classification of CKD. CKD due to chronic interstitial nephritis. If the patient has CKD due to chronic glomerulonephritis, that means the problem was in the the problem started in the glomerulus and progressed to CKD. If the patient has CIN, that is chronic interstitial nephritis, the problem initially started in the interstitial compartment, damaged the interstitium, further progressed up to the glomerulus, and later the glomerulus is damaged. So how do you differentiate CGN and CIN? CGN patients will have very less urine output and uncontrolled hypertension. CIN patients will have more of anemia, more of bone related disorders, but good urine output. Reason why? Here the CIN patients are glomerulus is normal. So filtration is occurring. So urine is coming. And erythropoietin is produced from the tubules. So anemia will be more. Vitamin D is produced from the tubules. So bone disorders are more. In CGN patients, anemia will be less, bone disorders will be reduced. Because here the tubules are normal, only glomerulus is affected. So we have to differentiate between CGN and CIN. Okay. So what I was answering? Yeah, mutations. CGN patients, because of the glomerular filtration has number of proteins, there can be mutation in the proteins and cause nephrotic syndrome called FSGS, focal segmental glomerulonephritisis, focal segmental glomerulosclerosis. Subsequently, this FSGS can lead to CKD. Okay, hope that answers your question. Genetic mutations. Can you please tell the name of the app, sir? It is EGFR app. EGFR app. Sir, if a patient is suffering from septic shock, where his kidney function is drastically reduced and doctors started dialysis, is there any chance that person can return to the normal state without that? Definitely, that is what is AKI. Sri Adi. That is what is AKI. AKI definitely recovers. That is why I call it as acute kidney injury. Like our, if you get a injury due to blade or anything, if you have a cut on the skin, it heals within 7 days. Where the endothelium and all those things completely, skin looks normal after 7 days. Same thing, kidney recovers from AKI after 3 weeks. So dialysis starting at once does not mean that patient requires a lifelong dialysis in AK. AK patient recovers from dialysis within 3 weeks. There is usually a complete recovery. Okay. Hope that answers your question. So sepsis is, if it is treated, dialysis will also go away. Patient will also improve. Sir couldn't
Thank you
understand.
so much, sir.
Sir could not the word irreversible be added? Bhaskar, you why could not the word irreversible be added to the definition of CKD? That is what you mean to probably. It is irreversible only. It is the progression. That is what we were telling. Over 3 months, it means it is irreversible. Though they have not mentioned the word irreversible, but it means the progression. Since 3 months, if it is there, it is irreversible. I have a doubt not regarding CK or AK condition, but regarding normal kidney function scenario, sir. Okay. As you said earlier that the functions are divided between both kidneys. Does creatinine levels here for or any other levels get altered when the person has only one kidney? Very good question. Who is this Sri Niharika? Yeah, very good question. See, for example, a patient has a left nephrectomy. Example, left nephrectomy. Left kidney is removed. Entire load of the body of filtration is shared by the right kidney, right? So what happens there is initially a stage of glomerular hypertrophy and hyperfiltration. So the kidney size enlarges from the normal size. This is we called as compensatory hypertrophy because it is overworking. It is as simple as person going to gym and exercising. If you do a normal exercise, nobody will develop good muscles. If you go to gym and over exercise, you will develop a good body physique. So it is the same thing. Kidney is also overworking. So there is an increase in size. This is called compensatory hypertrophy of the kidney. When there is a the inside glomerulus is taking more load. This is called hyperfiltration. When the hyperfiltration process is going on for quite a long time, there occurs called a hyperfiltration injury, and there is always a risk of CKD for this patient. But the CKD progression would be very slow. So you can ask the next question, like patient, if they are going for transplant, if the donor is donating one kidney, will the other kidney progress to CKD? Yes, the answer is yes. That but the chance is only 1 to 2%. It's very less. The compensatory hypertrophy going into CKD is very slow process. So you should not the person from donating the kidney telling this compensatory hypertrophy is nothing but CKD. It's a very slow process and it will take a long time. For example, 50 years mother is donating to his 20 years son. Hardly she would live for next 30 years. Okay, this compensatory hypertrophy and all those things would be going by the time she develops CKD. She is already 80-85. Okay, you understood this concept?
Yes, sir. And some people will be having single kidney from birth itself, no, sir?
Birth. Yeah, they will have a compensatory hypertrophy and they will go for CKD over a period of time.
Okay, what can be the precautions to avoid that,
That is
sir?
one more good question. Those kind of people should be followed up with their protein levels measured in the urine every 3 months to 6 months. When the proteinuria starts because of the compensatory hypertrophy, you have to keep them on ACE inhibitors. Okay, because
Okay,
they
sir.
manifest with the proteinuria. Good evening,
Okay.
sir. ACE inhibitors and ARBs are considered as renoprotective and also nephrotoxic. Sir, if ACE inhibitors and ARBs are inducing acute kidney injury in CKD, Divya, this is a $1 million question. ARBs are inducing acute kidney injury if the patient is not tolerating. Nothing much can be done, but if the provided that the potassium is normal, you can give aldosterone, mineralocorticoid antagonist, aldosterone. Even aldosterone prevents the progression of CKD. Okay, that is first answer to your question. Second answer is if the patient is diabetes, oral hypoglycemic agents. Now the recent trial has come, the DAPA CKD trial, which says that SGLT2 inhibitors are the drugs which we can given both in diabetic patients and non-diabetic patients also who has CKD. So SGLT2 inhibitors can be given for a patient who are non-diabetic also to prevent the progression of CKD. Okay, that is second thing. One is aldosterone, second is dapagliflozin or empagliflozin, whatever gliflozins it is, SGLT2 inhibitors. Third drug which can prevent the progression of CKD is your what do you say, DPP4 inhibitors to some extent. Though in a non-diabetic patient, it can be given. There are many other drugs like semaglutide and there are many uh, aminoglutamide, PPR, perfenadone, antifibrotic agents, perfenadone, and antioxidants, glutathione enhancing agents, which are not in the market as such. In the experimental scenario, pardoxal and methyl, aminoglutamide, allegibrium, all these are fantastic name drugs which are not in market. These are the drugs which can be tried in experimental animals to prevent the progression of CKD. The drugs which are available in market, more practical scenario is these things. Aldosterone can be given, DAPA, SGLT2 inhibitors can be given. Leader trial says that even this liraglutide and other things can be given. Okay, Divya, that's a very good
Okay,
question.
sir. Thank you, sir.
Just in dialysis patients, generally they are having anemia, but in some cases, even the hemoglobin count is near to normal, is 11.4. In this case, we should continue erythropoietin, sir. No, we have to hold erythropoietin in this case because according to the KDO guidelines, our target hemoglobin is only 11.5. You should not give erythropoietin stimulating agents beyond 11.5 hemoglobin, as it can produce other complications like thrombotic episodes, stroke, MI, accelerated hypertension, and access problems like AV fistula closure and all those things. So these are the problems when you give beyond 11.5. Our target is just up to 11.5. Up to 10 is the better. Beyond 10, you should not go ahead with erythropoietin stimulating agents. Tejasvi. Will erythropoietin replacement affect? Yeah, understood?
Yes, sir. Thank you, sir.
Will erythropoietin replacement affect HbA1c levels in diabetic patients? No, it does not. It does not.
Okay,
Question
sir.
from you.
Yeah.
Is meropenem 500 mg safe in CKD? I have seen patients are given meropenem totally avoiding other antibiotics. Definitely meropenem is safe in CKD. There is nothing like meropenem should be avoided, but dose should be adjusted according to the GFR. You can adjust according to GFR. It could be once a day, twice a day, or thrice a day too. I have seen patients are giving meropenem totally avoiding other antibiotics. I didn't understand the second part. You mean to tell that meropenem to be avoided or other antibiotics avoided and meropenem is given? I didn't get the second part of the question. Okay. Which antibiotic is preferable and ideal in a CKD patient on dialysis for a catheter related infection as empirical therapy? Oh, intelligent question. So definitely we would prefer to cover MRSA, and that would be definitely a vancomycin or a teicoplanin. Or if your hospital culture reports for line related CRBSI infection is more of MSSA, then penicillin would be definitely the drug of choice, cifazole and other things. But most of the hospitals acquired infections are MRSA. So preferably the empirical therapy would to be to cover MRSA and gram negative. Both you have to cover because it could be a gram, because it is the lines are in the hospital and the patient is coming to the hospital regularly. So it should be both gram negative coverage and definitely MRSA coverage. Okay, gram negative coverage, we can go ahead with the BLBLA group of antibiotics because most of the organism is hospital acquired and it will be ESBL organism. So I would like to consider a BLBLA group plus vancomycin. Praveen, that answers your
Yes, sir.
question.
Thank you so much, sir. Yes, sir. Thank you so much, sir.
CG versus CKD, cockroach gold formula versus EPI versus MDRD. Which is more accurate readings and how much variation in EGFR and GFR? Rohit, this is a very difficult question. See, everything has an plus or minus risk and benefit ratio. See, MDRD formula was designed in different population in Japanese population. The CKD EPA was different, designed in a separate population. These formulas were not tried in a uniform population. You have to remember that because the race of the people definitely has a significant effect on the GFR. What we are using in 1.73 meters square in GFR is not Indian data, it's a Western data. First of all, MDRD formula will be more useful for liver cirrhotics and all those things for muscle mass obesity is definitely a significant factor. CKD EPA can be used when the other confounding factors are much, like patient is extremely lean, extremely obese, all those things. So there is nothing like this is superior, that is inferior, but among all the things, CKD epi formula has more greater accuracy and more greater, what do you call, like it is more closer to the correct, more accurate. Let me tell it is more accurate. Okay, Rohit,
Okay, sir. Okay, sir. Thank you, sir.
you were not satisfied with the answer, or you are okay?
I was satisfied, sir.
Okay, because it is done in various populations.
Yes,
But
sir.
now, presently, the scenario is to take a CKD EPI formula into consideration. Because MDRD can be used for liver cirrhotic patients, that would be more for beneficial for them. Question
Yes,
from
sir.
YouTube, Anupama. If the patient is diagnosed with CKD recently, the regular using antihypertensive, antihypertensive should be changed or continue as such. Good question. Antihypertensives should contain at least an ACE inhibitor or ARB if the patient is tolerating well. That is answer number one. Second, because the ACE inhibitors and ARBs prevents the progression of CKD, your antihypertensive should contain one definitely ACE inhibitor or ARB. And if the patient is not tolerating well, antihypertensives need not be changed because our target is to get the BP below 140/90 in a patient who is not losing protein and below 130/80 in a patient who is losing protein. How do you get, in what way do you get, that is immaterial, but you have to get to these targets to prevent the progression of CKD. That's all it is. If you can add an ACE inhibitor and ARB, patient is tolerating well, there is no hyperkalemia, no other problems. This will become the first drug of choice. Okay. Mm,
Hello, sir. Hello.
mycophenolate or cyclophosphamide, which one is better to prescribe in a patient on lupus nephritis and dialysis? First of all, Bhargavi, if the patient is on dialysis, that means it is CKD stage 5. The patient is already progressed to stage 5 CKD. Your lupus treatment was a failure. That's all it is. So you will not obviously prescribe mycophenolate or cyclophosphamide for the kidney protective strategy, because the patient has gone into CKD. What else you want to treat for a lupus patient? Once he go into CKD stage 5, there is nothing to help the patient. Moreover, once this is in CKD stage 5, your immunosuppressions will create more harm than benefit. Why did you get this doubt, Bhargavi? Hello? Hello? Okay, fine. So we don't prescribe immunosuppressants for a lupus nephritic patients on dialysis because we treat lupus nephritis before to prevent the progression for dialysis, to prevent the progression of CKD, to prevent the progression of renal injury. Once the patient is in dialysis, it is no use. There is one chance. Probably I understood why she asked this question. Patient with lupus nephritis on dialysis could be a rapidly progressive renal failure. Though in those patients also we dialyze, but once you give cyclophosphamide or MMF, these patients tend to improve. This is a scenario where you can give cyclophosphamide or MMF, that is called RPRF, rapidly progressive renal failure, that is class 3 or class 4 lupus or class 5 lupus. There are classes in lupus, class 3, 4 or 5. Those are the patients who present with acute kidney injury. Acute kidney injury secondary to lupus. We treat with immunosuppression, give cyclophosphamide when they are dialysis dependent. There is no harm in giving MMF, but when the patient is having very sick, dialysis dependent due to lupus nephritis, and you feel it is acute kidney injury, you have to treat it rapidly. That is called crescentic or rapidly progressive lupus nephritis or crescentic lupus nephritis. Crescentic lupus is rare, but class 3 or class 4 lupus nephritis. DPGN we call. Diffuse proliferative lupus nephritis. I think Bhargavi, that answers your question, or you left? Hello, probably she's not there.
Actually, she is there, sir, but maybe unable to speak.
Achha, no problem.
That answers the question, sir. Sir, and next question you should definitely answer, sir. Every time you will avoid. So, how do you keep up with so much information, sir?
We'll go to next question answered by Kader, asked by Kader Shoaib. This will answer later, Karthik. I would like to ask you regarding management of CKD in pregnancy and how do you manage polypharmacy related problems during breastfeeding? Wow, this question is really, Kader, this is a wonderful question. Management of CKD in pregnancy and breastfeeding problems is a completely different topic. I would definitely love to talk on this, but see, uh, CKD prognosis. The reason being, the uremic environment does not allow the fetus to develop. First answer. The uremia, that is raised blood urea and serum creatinine, does not allow the fetus to develop. So the patient will have more chance of abortions. If they cross 20 weeks of gestation, there is more chance of IUD, intrauterine death. There will be intrauterine growth restriction. There will be early delivery. There will be preterm delivery. There can be intrauterine death. These are the effects of CKD on pregnancy. Moreover, CKD patients are hypertensive. So, in pregnancy, the CKD hypertension worsens and it causes a preeclampsia superimposed on hypertension. This condition is very bad because the patient are more prone to develop preeclampsia. So, if the CKD patient is planning a pregnancy, you should warn her about the abortion, UGR, intrauterine growth restriction, IUD, preterm delivery, and preeclampsia complicating the pregnancy and anemia complicating pregnancy. Okay, first thing, if the patient and the GFR can worsen also. I'll tell you an interesting fact. If the patient serum creatinine is 2.5, for example, this patient gets pregnant. After 1 month or 2 months, you check her serum creatinine. Now it is 2. So what do you think, Shoaib? This patient has improved after pregnancy? I want to answer
Yes, sir.
because this question
Basically,
was very intelligent.
yes, yes, sir. Basically, it looks like from 2.5 to 2, then there is the improvement.
Any other intelligent answers?
So it is affecting the fetus. Fetus is absorbing or
Sorry, I cannot hear you clearly.
it might be
Okay.
affecting the be
Yeah, okay. Let me answer. You should know what are the physiological changes of pregnancy to understand how CKD behaves in pregnancy. In pregnancy, I hope everyone knows that there is volume expansion. Whenever there is volume, because the fetus also needs more blood, normally from 5 liters to it volume expands to 6.5 liters. The RBC counts increases from 30%. The plasma volume increases definitely. The heart rate increases definitely. So all these factors leads to volume expansion. Whenever there is a volume expansion, the GFR is also increasing. So the normal creatinine values pregnancy is not 0.7 to 1. The normal creatinine value in pregnancy, because of the improvement in GFR, is 0.3 to 0.4. So there is a false drop in creatinine, but it's not a true drop. Hope you got the concept. Sure.
Yes, sir. Yeah.
Yes, sir.
Very good. So if you understand this concept, in pregnancy, the creatinine dropping is not a good sign. I mean, it's not a good sign in the sense it is not a true drop. Don't be happy. It's a increase in GFR physiologically. Any pregnancy with more than 2.5 creatinine is not good prognosis. Not good prognosis. One more scenario I'll tell you. With the pregnant patient who is dialysis dependent, fortunately, if she becomes usually dialysis patients will have a menstrual abnormality and they will have unovulated cycles and ovulation is not proper because the luteinizing hormone and follicle stimulating hormone is very low because of the uremic environment. Fortunately, if the patient becomes pregnant, usually we do dialysis 3 times a week. That is for a normal person. For a pregnant patient, you have to do dialysis every day to keep the uremic environment very low. You have to keep the blood urea less than 40, creatinine less than 1.5 or 2. So at least 20 hours a day, 20 hours per week, dialysis is required for a patient. Just hold on, I got a call. Sujat बोलिए. HRCT कंपलसरी बोल रहे हैं, हॉस्पिटल प्रोटोकॉल है. कौन है उधर? रिजवान है, रिजवान को फोन दीजिए. श्रवण सुजात और क्या है, एक फीवर था ना, फीवर डायरिया. करा लो सुजात, बेटर है. हाँ. Sorry for the interruption. So Shoaib, hello.
Yes, sir.
So that answers your question of CKD in pregnancy.
Yes, sir.
Is it clear? So we have to dialyze at 20 hours per week to keep the uremic environment low. And how to manage polypharmacy related problems during breastfeeding? That is very difficult to answer. That depends on the number of drugs she's taking, and we have to keep as low as possible. That's all we can do. Sir, is there any effect of oral contraceptive pills in the management of CKD? Oral contraceptive pills can progress CKD because of the thrombotic episodes it can have, and that's all. Nothing much. They
Sir,
can
all
have
questions you
thrombotic
answered,
episodes.
sir.
Huh.
So, but one final thing is just we want to know how your student days were, sir, in MBBS, MD, and DM. How you used to learn all these things, and just give us few tips
I
on
really
learning.
do
Every
not know,
time you
Karthik.
skip that question, sir. You should this time something. Maybe just you can talk about how sincere you were and how many cases you are seeing every day in your student days, sir, both MD,
No, it's not
DM, and
about how
also
sincere
MBBS.
I was. I was like routine everyone, but we would like, because what I used to do from apart from other things, I used to go and see the finding. If the patient has some interesting finding, I used to go and repeatedly examine that patient every day. So despite I know that finding is there, and I was convinced that it is, I have seen today and I was satisfied. Despite that, I used to go and re-see that finding and again and again. So after doing that, I found that much more every day I used to find a new thing in the same old patient. So that helped me one thing, and the other way around is that gain the patient's confidence. Usually in a student life, patient won't allow you to touch because they will tell that పెద్ద డాక్టర్ వచ్చిండు చూసిండు అయిపోయింది
Yes, sir. Yeah.
వెళ్ళిపోయిండు, మీరు ఎందుకు వస్తున్నారు మళ్ళా మళ్ళా. దట్స్ వాట్ దే సే. So what we used to do, we used to give some money to the patient, get some food to the patient. We used to ask, did you have your breakfast, lunch? We used to give some food to the patient and examine him because we were interested to see the findings. So that is the way we learned. That's all.
Okay.
So,
And can you talk about any experiences of you with Fandi, sir? So even now Zuzair is with you, and we met in fifth year, though that was for brief time. Later we were in touch. So basically,
yeah,
how do you
it's
think all
a
of us can help
very
him to?
because he's there. It was very helpful for us because we will tend on committing mistakes because of the patient load every day and the busy schedule, OP, IP management. So many patients, our brain continuously don't work for every drug interaction. Okay, so it is always a problem there, like having multiple drug interactions which you don't concentrate, and that really helps when somebody comes and tells her this is wrong. If you do this, this would be better, and this is the way these drugs interact and cause more side effects. That gives a really great help, and we'll go back and read back because we don't think that we are 100% we know everything. We are not gods. We are not gods. So we also tend to learn new things every day. So I personally feel that you should help. We should work together and interact more and more. instead of thinking that I know everything. And that helps in the management of the patient in a better way. So, what I feel is after introducing this course, the patient management has improved significantly, and the side effect profile has come down significantly, and the and iatrogenic effects have come down definitely to much better level, because we don't monitor heparin properly, we don't see adjustments of heparin properly. But so first time when we see, but second, third time sometimes it goes above the head, because patient will be talking, counseling, and all those things happen. There'll be multiple things going in the mind of a doctor. So definitely, when somebody else is there to help, who is thinking only regarding this part and not interacting with the patient much, so then that minds we need, definitely. Those minds we need. That's what I feel.
Yeah, so thank you so much, sir, for giving this confidence, because many students face resistance from doctors when they try to not point out, but even politely, if they say something they don't readily accept or give, it's create that ambience where student can open up and share his thoughts. And last
Definitely,
thing is,
definitely.
yeah, so any tips for our family students, sir? You have been training us for last few years, at least from 2013. Many students are doing well, but finally to succeed in career, do you want to give them any suggestions?
Nothing much. I would suggest please follow. Don't go into the false track. See pseudo tracks uh, that that opportunities are lessened. Also, the world is open for you, and the opportunities are open for you. It is the way you search and dig out the opportunities. Nobody will keep a ready place for you and keep a fancy chair ready welcoming you. You have to dig your own opportunities and proceed. See, the life we walked is not, it was not very easy. We walked over thorns and came to this stage. So I would suggest don't wait for the opportunities. Go and dig your own opportunities, and you will have a great future ahead. And don't lose the sessions conducted by Karthik. That's what I would say, because these are the conglomerate. Like see, you don't get so much from everywhere. So if you attend one session where there is a CME going on or whatever he is conducting, there are many experienced people talking over from various platforms. So you can learn it and get more information in a shorter time. I would seriously and strongly request everyone to please make utilize of these sessions. What I'm talking clinically, it may not be relevant to you, but there are plenty of other sessions which is making use to make you updated regarding various information. So please don't miss those things and don't think it may not help you. At least, if not now, one point would be definitely helping you in future coming days. Yeah. Okay.
Yes, sir. So thank you so much, sir. And actually, in this mentorship program, we are going to have at least 50 sessions, sir, not limited to clinicians, but we also have sessions from startups and lifestyle.
Yeah,
Yesterday,
yeah, I know.
we have lifestyle medicine, sir. On Sunday, Sai Praveen sir will be taking on critical care.
Wow, super.
So
Amazing.
there are a lot of interesting
So
sessions coming.
that's what I'm telling. There are many big people, and a small drop in the ocean. Ocean is very big. I'm a drop in the ocean just speaking, but you have many big people coming into picture in future. Yeah, I'm
And
just
now,
a drop in
actually,
the ocean.
sir, we are very happy that you found little time. Earlier, I know how difficult it was to get your time. I was extremely happy when you said, Karthik, like I will be free in the evenings. So definitely after 1 or 2 months, maybe one session in a week, I want to request from you, sir. If you see the chat box, it
Okay,
is filled with a
sure.
lot of feedbacks, and definitely students will learn a lot.
Yeah.
So
Thank
thank you
you,
so much.
thank you.
If somebody
Hope
else
it is
wants to give
not
a feedback,
boring.
definitely not, sir. So one last thing is, if any student wants to unmute and give a feedback, you can do now.
Hello,
The
sir.
rest we will take on. Yeah.
Yeah.
Hello, sir. This is Satya.
Hi.
Sir,
Hi,
actually,
sir.
Satya, one second. So he was one first student, sir. The module which we started in Vardhan College in Kukatpalli, the first
Yeah,
batch.
Acha, acha.
Satya was part of
Okay,
that.
okay, okay.
I've been listening to you from past 3 years, I guess, sir. Like I still feel fresh to listen from you,
Thank
sir.
you so
Like
much.
Thank you so much for all
Thank you,
your
Ma. Thank you.
efforts, for your time. I really appreciate your time, sir. Like, I don't know how to express it. I really bow down for your time, for educating students, like especially family students, on these areas. Thank you, sir.
Thank you, Satya. Thank you. Thanks a lot. So, Karthik, I want to ask this: these sessions are updated in YouTube?
Yes, sir. Yeah.
Previous sessions?
Previous session it was not live streamed on YouTube, sir. We recorded it and uploaded on YouTube. This one is live streamed, sir. So easily around
Oh,
thousand
okay,
more
okay, okay.
students are.
So I should be more cautious while talking. Maybe I'm talking more of. Okay, fine, fine, fine. I'm sorry. Yeah. So previous sessions are updated in YouTube
Yeah,
because
yes,
it
sir.
will be
So
useful for others.
yes, sir, and that got close to 4,000 views, sir. Uh,
Yeah. Okay. Well, like what we have taken, I don't remember. I think one my medical emergencies got updated.
the one you took recently, sir.
What all sessions we have taken, I don't remember
Only
exactly.
one, sir, actually on YouTube. Earlier, we were.
Yeah, sepsis. Okay. What about medical emergencies?
No, sir. Actually, only one we uploaded, sir. Actually, on Google Meet, this is your third
Also, we
session,
can
sir.
do so that other people who have missed it can at least have listen. Okay.
Yes, sir.
Can we do that? Medical emergency, if you have that recorded,
Yeah,
so
we will do,
it
sir.
will be
We
beneficial
will.
for the people who missed. That's what I felt.
Yes, yes, sir. So actually, we are means we edit, sir, few parts and then upload. So maybe for that reason it got delayed. So definitely all the sessions you do, we will upload on YouTube, sir. Like if
Sure,
students
sure,
missed
no
it,
problem. So that
watching it. Yeah.
people who miss will be benefited. Yeah, fine.
Hi, sir.
Okay. Hi, ma.
This is Akila, sir.
Akila, yeah, I know you.
Yeah, yeah. Actually, I'm very glad to be part of your session, sir. The first session I heard from you is emergency cases.
Yeah.
That session was really. I loved the session, sir. From that
Thank you.
session, I became big fan of you. I don't want to miss even one session.
Thank you.
And even
Thank you.
that session also helped me, sir. In emergency, I have seen a hypoglycemic patient, and I used to correlate whatever you have said in the session.
Okay.
Yeah, all these sessions were really helpful, sir. Thank you for your valuable time and guiding us in on
Thank you, ma.
practical issues. Thank you, sir.
Yes.
Thank you, sir.
So
Okay, sir.
shall we
Shalin, I
can?
think we end the session. Yeah, thank you so
Yeah.
much, sir. Like,
Thank you,
yeah, bye,
Karthik.
sir.
Thank
Take
you.
care.
Bye, ma. Bye.
Thank you, sir.
Thank you. Thank you.
Thank you, sir.
Thank you, sir.
Thank you. Thank you.
Thank you, sir.
Yeah.
Thank you,
Thank you.
sir.
Thank you.
Thank you.
Thank you so much, sir.
Thank you, sir.
Thank you, sir. Thank
Thank
you.
you, sir.
Thank you.
Thank you
Thank
so
you.
much, sir.
Thank you.